Good morning, Doc. You had sent over this case for a review. 70-year-old female looking to decrease her risk on future tooth loss. Anytime I look at a case like this, the first thing I want to ask myself is the following. Of the three following categories, which category does the patient fall into? Is this a perio patient? Is it a high caries risk patient? Or is this a high biomechanical risk patient? Although some patients fall into two or three of these categories, patients tend to fall into one. So I wouldn't call this a periodontally compromised patient. In great part, she's 70 years old and has very little, if any, generalized clinical attachment loss. Sure, there's isolated, but I would chalk that up to biomechanical problems, not necessarily presence of the red complex, which is essentially the microbial makeup of a periodontal patient. But in this situation here, I would classify this patient as a biomechanically compromised patient. So what I mean by that is the muscles and the masticatory system have not functioned in a way to support continued presence of posterior teeth. So we see this a lot. Posterior tooth loss not necessarily associated with either periodontal disease or high caries risk. Again, those things are contributory, but I think it's important as we start to build the treatment plan that we understand the environment in which we're putting solutions into. Super important. Understand the environment in which we're putting solutions into. So let's take a look here. Of note, this was a recently extracted tooth, had a very compromised surrounding bone structure, which is why it looks so bad here. In essence, that tooth was removed a few days before the scan, so I wouldn't put a whole lot of focus and attention on it at this point, other than what are we going to do to replace that. So here we have the patient. Let's just take a look here. I would call this age-appropriate wear. This is not something significant. If this was a 20-year-old, I would be concerned. But in a 70-year-old, this is not something that I would say is contributory. This patient does not spend a whole lot of time wearing their front teeth. Yes, there's stress here, but again, age-appropriate. So let's go over to the CAT scan. And with all CAT scans, what I like to do is treat this almost like I do with perio probing, where I start in the upper right, go to the upper left, come down, lower left, lower right. But I'm not just looking at the teeth. When we take CAT scans, we need to be somewhat qualified in our ability to understand what we're looking at. If not, we should bring in the help of a oral radiologist. But in essence, what I'm doing is I'm taking this green line here, and I'm going from the upper right to the upper left. But see how far back I'm starting here. If we take an image, we have to be responsible for the information held therein. If I see anything that looks abnormal, I'm going to send it to beam readers or some other oral radiology company that can provide a radiology report for these volumes of information. So what I'm doing, I'm looking over here, and again, this takes experience to know what you're looking for, but I'm looking for aberrations. So I'm looking over here as I pan this. So there we have the mandible. There's our inferior alveolar canal, nerve canal. Now we're starting to come into the posterior section of the maxillary tuberosity. Here we have our maxillary sinus. We have some thickening of the sinus, and here we start to see the roots of probably number one. Now, when I start to see thickening of the Schneiderian membrane associated with or adjacent to teeth, it's not atypical to see thickening of the Schneiderian membrane next to teeth. As you start to look at these kind of slices more and more, you're going to gain a sense of what are the things that likely need to be seen by the ENT, and what are the things that are likely to resolve if and when the odontogenic origin has been removed. I'm not putting a whole lot of stock to this right now. It looks rather typical to thickening of the membrane associated with the apex of a tooth. This tooth looks compromised, so I'm not surprised that if there's infection inside of this tooth, that the Schneiderian membrane, which is a biologically active entity, would inflame in response to the presence of that infection. Which is why sometimes when we have sinus allergies, we get thickening here. We have patients who have increased nerve sensation, pain, dysesthesia, or what have you, associated with adjacent teeth. But I'm coming across here, now I'm starting to come across number 3. Number 3 has endo treatment. As we can see, root canal here on the distal buccal canal. Again, thickening of the sinus. Now this guy up here might be a polyp. It's not associated with the teeth, but one can imagine that these things exist in people all the time and we just never see them. So working with our ENT colleagues to get a better sense of what requires or what constitutes a referral is an important part of this conversation. But it's important to note that a lot of times these periapical radiolucencies associated with many teeth, specifically previously endodontically treated teeth, this would be very hard to see or notice on a periapical film, on a two-dimensional periapical film. You have all this cortical bone, dense cortical bone, which provides very little contrast to a radiolucency when looking at a two-dimensional image that's orthogonal to this view. Point being, we see things on CAT scans that we don't see otherwise. I think the scientific world, or at least the dental literature, is going to resolve what to do with these things. I've had this conversation with many endodontists, and in general, if there's no pain, if there's no symptoms, there's no fistula tract, then they just leave it. That just might be the body's response to a low-grade infection. I can't say whether that's contributory towards systemic disease or not. But in a nutshell, I think it's important to let patients know when we see things like this. So number 3, I would say, is potentially compromised because of that. So now we're coming over to the edentulous site number 4. I don't know when this tooth was removed. If this was removed in the past year, I wouldn't be concerned. But if this tooth was removed greater than a year ago, I might consider a referral to the oral surgeon. I did look at her medical history to see if she was on bisphosphonates. This just looks funny. Again, if it was a healing socket, I wouldn't put any concern here, but I don't have that information because she's a new patient. So I would follow up on this. If this is potentially let me reframe that. If this patient had this tooth removed greater than a year ago, then I would bring some attention to this area. Again, she's not on bisphosphonates. Fortunately, if she was, I would probably send her right to the oral surgeon and send them this image and your concerns. With that said, I'm just going to assume that this is probably a recent extraction site that is in the process of ossifying. I'm looking at the alveolar ridge here, and that just looks rather irregular with some opacification. It again looks funny. All right, so now I'm coming across tooth number 4, and again I'm looking at the apex. Everything looks good there. As you start to look at these more and more, you're going to see things like this. This is not pathologic. This is just an artifact of the slice that we took. And you'll start to develop what we mean by that. There's still some trabeculation in there, so I know that's just a artifact of the slice. When I'm in this area, I'm also looking at the turbinates and the adjacent nasal mucosa. That's rather thick. This patient probably suffers to breathe through their nose, not surprising, as many people do. There's also what looks like a palatal tori in the midline here, which we saw on the iTero scan. This patient may or may not be somebody who suffered from inadequate expansion during craniofacial development, which leads to poor nasal breathing. We'll come back to the nasal breathing part. But as I come across, it's very evident that the patient probably has chronic sinusitis or allergies or both, or something that's causing nasal mucosal swelling. So I think seeing our ENT colleagues would be a nice benefit to the patient's overall health and well-being. So again, I'm coming across and I'm looking at the apices of the teeth. I'm not seeing much here. There's our nasal palatine canal as we switch over to the other side. Not much going on. And as we get to number 13, we start to see a little bit of widening of the PDL. When I see widening of the PDL that looks rather uniform like this, I'm thinking it is occlusal. This patient has posterior tooth issues. I would assume that some teeth, or maybe at least one tooth, is getting overloaded, and that's potentially what we're seeing. This is the kind of thing we see when a patient has active ortho or recent orthodontic treatment. So just put some special attention that this tooth is probably getting overloaded biomechanically. So then we come over to the recent extraction site. Some leftover gutta percha, thickening of the Schneiderian membrane, but not a whole lot of bone here. This will fill in to some degree. But this patient, if she wants an implant in this site, is going to need a rather significant sinus lift. But look at where the bone is potentially going to end up. You can imagine an implant starting here and going up is going to be a tall order. It's definitely done, can be done, but the amount of surgical reconstruction that's going to need to be done in this area is going to be rather significant. So understanding the surgical side of this is important as you start to treatment plan, because the last thing you want to do is put together a comprehensive treatment plan that says implant here, not knowing, one, how much surgery is going to be needed, but two, even if the surgery is good, the potential crown to implant ratio that's going to be present after the fact. Just to get a sense of where I would see this bone setting up. When you remove a tooth, you're not going to have bone fill past the most coronal extent of the alveolar socket, which is this guy right here. Sorry, there's a little lag with the computer. So, best case scenario, and I doubt it's going to go this high because of how deficient it is on the buccal. I think you're probably going to end up with something like this. Again, I'm thinking about the future alveolar ridge of this particular site. The head of the implant is where this orange line is. Then you're going to have a very large crown on top of that. Again, without question, a sinus lift is going to be needed to get honestly, I would like an 11, 12 millimeter implant here because of how tall the crown's going to be, which wouldn't be difficult. We calm the sinuses down, we remove the infection, and then do a sinus lift. But again, thinking with the end in mind. So now I'm coming back over to the green line, and let's take a look at tooth number 15. Again, just general swelling of the nasal mucosa of the maxillary sinus and the nasal mucosa. So I think this patient really would benefit from our ENT referral. Tooth number 15 looks good, at least radiographically. But I continue moving on. I want to make sure that there's nothing that looks weird or aberrant in this section here. Depending upon the patient's workup, a lot of times I'll look at the joint. Here we have the beginning of the head of the condyle. It's very difficult to get an entire volume of information, including the condyle. If the patient has TMD, then I'll take a separate scan to capture that information. But I wouldn't do that routinely. I'll let the patient's symptoms and signs dictate whether or not you need to radiograph the joint or not. All right, so now that I'm done that, I'm going to come over and I'm observing the lower section. Here we're looking at the mandible. There's our inferior alveolar nerve canal, which is this guy right here. If you're ever wondering the location of that, take this orange line, put it right over what you see here, and it superimposes that. Again, looking at the apices of the teeth. So now I'm looking at the bone down here for a potential future implant. We could map out the nerve. It's right here. Maybe a topic for another day. But just to get a sense of how much bone you have here, you have plenty of bone for an implant. 15 millimeters. I mean, if you had 10 would kind of be the minimum of vertical height. If you had 10 millimeters between the nerve and the alveolar ridge, you could place an 8 millimeter implant with a 2 millimeter buffer zone. There's ways of making sure to keep the nerve safe. Topic for a surgical conversation. But 15 is a lot. I wish all ridges had this kind of bone. More often than not, the ridges are normally deficient in buccolingual dimension. This is a very good ridge to place an implant. So 8 millimeters is really good. It might be a little bit lingually biased, but this is a ridge we can work with. So we can place an implant there without any ridge augmentation. So these are the thought processes that go behind comprehensive treatment planning using the CAT scan. Again, looking at the apex, here's our mental nerve coming out, inferior alveolar nerve canal emerging through the buccal. Nothing earth-shattering there. Here we have a tori or torus. If I ever wonder, I want to look over at the other side to see if I see one. When aberrant things are bilateral, they tend to not be concerning. So I always double check. I do see the torus there. So I'm going to come back over. So this is tooth 23. That looks a little concerning. Maybe just endo test it, endo ice, EPT. Coming over to the other side. So for the most part, the teeth that she has remaining are relatively stable. You know, this is a great foundation to do a comprehensive case on. Looks like there might be a small infrabony defect on the lingual of number 30. My guess is periodontally that's potentially compromised. There's probably a piece of tartar sitting right there that's causing this localized vertical defect. One of the nice things about a CAT scan is we have that third dimension. You would never see that radiographically on a PA, at least not in this part of the tooth. It often has to wait till it gets much worse for it to wrap around the mesial-distal until we see it there. And then number 31 looks relatively okay, even though the fill seems rather short. The bone around it seems okay. Important to note, look at the proximity of the root tip in relation to the nerve. So if this tooth ever needed to come out and you wanted to degranulate that area, something you'd want to be careful for. So in a nutshell, that's the radiographic analysis of the CAT scan that I think is important for these comprehensive treatment plans. You did a great workup, which I'll bring over here. I anonymized the patient just so I could put this on the YouTube channel. But essentially the patient, articulated, I don't want to lose any other teeth. You put together a nice problem list here. I would put loss of alveolar bone in the upper left due to severely infected tooth. Number 14 really just, that's such a problem area that the patient should be aware of, which might advocate for the idea of a bridge or partial. medications, nothing earth-shattering there. There are considerations, but nothing that's going to change the presentation of treatment options. Patient's desires and goals, replacing missing teeth and reducing the risk of losing any additional teeth. Our BruxGuard does a wonderful job with that, something that we tend not to consider for patients as a risk mitigation tool, but we kind of wait until the patient is a bruxer. Well, we can put bruxing guards in patients that aren't necessarily bruxers, and this reason alone is a great reason to do that. So whatever option or strategy you choose, even if the patient chooses nothing, a night guard would help at least satisfy that particular patient desire. So then you put together the options here. I love the detailed nature, the pros and the cons that you had outlined. The only thing I would say, the goal isn't to have patients spend a lot of money. The goal is to present all of the options, and hopefully they choose an option that is of high predictability for two reasons. One, it's more fun to do. It's more fun and satisfying to do dentistry that is predictable, but it also comes with a higher earning potential for the provider. Notice I put those in that order. With that said, our goal isn't necessarily to present all the expensive options. I think here, option one, we could do some partials and have the partials be somewhere in the range of, as low as $3,000. So one could imagine, because of the relatively sound foundation of her teeth, maybe this guy needs to come out, but if it's not presenting any issues and the position of this tooth is not periodontally compromising this tooth, then maybe we just keep that there. Just two partials might do her very well. Then you can provide more comprehensive options, like let's put a crown and then a partial surveyed crown and kind of shore up these teeth with large amalgams, which I do think is a good strategy. But I think as an entry-level option, we should always put the most affordable, predictable option, and I think that would be partials. So upper-lower partials, somewhere around $5,000, $2,500 an arch, which kind of seems like overkill for her particular situation. We might want to consider doing a bridge for $3,500 in the upper left, or bridge over here, 3 bridges, and she's probably going to be in the same price range as some of the implant options. So the only modification I would make is having this be a more affordable option. The first option should be the most affordable yet predictable option. Again, we always say no treatment is an option. That verbiage is up here. Let's just make sure it's in here. I thought somewhere in this verbiage it said no treatment is always an option. Yeah, so I would make sure we add that up here somewhere. The rest of these options I like. The comprehensive option might be overkill for this patient. Doing orthodontics, although, is ideal. I don't know if straightening her teeth is going to necessarily improve her long-term outcome. With that said, definitely an option. What should we do? What would be an ideal option here? To be honest, I would probably do a 3-unit bridge here. The amount of surgical intervention here would be rather significant. It's very difficult, if not impossible, to grow bone vertically with any sort of appreciable volume gain. When I say vertically, from the alveolar ridge coronally, it's very possible to grow vertical bone going up into the sinus, but then that's a different direction. And again, the implant crown that would be here would be rather top heavy. Definitely can be done. If the patient wants that, we can definitely do it. It just comes with some reservation. So a bridge in the upper left, an implant here because of the fact that the bone here is really good. I also like the bone here, especially if this site has no pathologic nature to it. Again, if this tooth was removed somewhat recently, and based on the tissue look here, I would say that's of high likelihood that this tooth was removed in the past year. I don't think this particular site needs any bone grafting. So if we come over here, if everything heals well, that is a very good ridge to place an implant. So, great option would be 2 implants and a bridge, maybe a crown and a crown. That would be a very good cost-conscious option. I love the idea of ortho, crowning all the teeth that need to be crowned, resetting her bite. I love those ideas, but at 70, that might be overkill. With that said, our job is not to opine on whether that's overkill or not. Our job is to educate the patient and let them make that decision. Huge distinction. All too often as doctors, we try to limit our presentations based upon our own opinions and judgments. That's what gets us in trouble, and it's what limits patients from really sometimes getting the care that they really want. So, on that note, let me know what you think, and I know you're meeting with her later this week. I'd love to hear how it goes. Have a good day.